global prevalence of injecting drug has been increasing recently rapidly. And to pace with that, infectious complications related to injection drug use are rapidly increasing. And with that sharp increase in that use of acute healthcare service, management of drug-induced endocarditis is particularly challenging because of high long-term mortality and morbidity in young population, as well as psychological environmental factors contributing to recurrent substance use and reinfection. Now, compared to the general population, intravenous drug abuse is associated with up to 100-fold increase in the risk of endocarditis through several mechanisms. One is that endothelial injury from injected particulate matters, and second is direct injection of contaminated material, drug-associated vasospasm leading to intimal damage and thrombus formation. Now, regarding epidemiology, that compared to unselected cohort infected endocarditis, individuals with drug use associated infected endocarditis typically younger and more likely to have prior endocarditis, more frequently have comorbid HIV infection and hepatitis C infection. They are more commonly homeless and or experience significant poverty. And patients with drug use associated endocarditis also present more frequently in native tricuspid valve endocarditis and concomitant septic pulmonary emboli, and more likely to have Staphylococcus aureus infection and higher rates of recurrence of infection. Now, recently there is a trend of change of epidemiology, that they are more common in young women and more commonly involving that 15 to 35 years of age, rather than previous of involvement of mean age was 34 years. Now, landscape of dual drug use as infective endocarditis is changing, as I have already discussed. Through prospective international cohort data, they are showing they are 40% affecting the left-sided heart valve, and there is more prevalence in women, I have already mentioned. Multiple studies highlighted the lower mortality rate at index hospitalization in persons with drug-associated endocarditis relative to those individuals who don't use drug, likely because they are more young, right sided valve is infected, and concomitant comorbidities are less. But lower short-term mortality does not translate into favorable long-term outcome, most often caused by return of continued drug abuse, and the risk of readmission caused by subsequent endocarditis, septicemia are significantly higher in drug-associated endocarditis. And 90 days readmission is around 22 to 49%. One of them were continuously going to use IV drug. Now, diagnostics of drug use associated endocarditis, apart from history and physical examination, chest radiographs show that pulmonary congestion or chamber enlargement, the ECG showing conduction disturbances, particularly aortic valve involvement with periannular abscess. Echocardiography, that transthoracic echocardiogram, 50% sensitive for prosthetic valve, whereas sensitivity both prosthetic and native valve endocarditis in T is 90%. T should be done in all patients because it detects that all valve and subvalvular apparatus, along with extension of that abscess or fistula formation, or that tract that dehiscence formation. Right-sided endocarditis, which is frequently seen in patient with drug use associated endocarditis, transthoracic echocardiogram is more sensitive because of anterior location of the tricuspid valve. There is advanced imaging technique, that MD CT angiography or electrocardiogram guided cardiac MRI, as well as FDG or PET scan or leukocyte scintigraphy can add to the diagnosis apart from echocardiography. MD-CTA visualization of perivalvular abscess such as and pseudoaneurysm identified, and also identify 40% of the fistula. CT angiography can add evaluating coronary arteries preoperatively, and electrocardiogram triggered multiphase imaging acquisition reconstruction with addition of fourth dimension time can add assessment of valve motion and presence of vegetation. So recently MD-CTA has been used as a modified diagnostic criteria for infected endocarditis by ESC. Now, FDG or PET scan and leukocyte scintigraphy have caused diagnostic value in that devastated infection. Whole body scan with these modalities along with MD-CTA can additionally identify extracardiac infection like septic pulmonary embolism. And FD scan is effective in detecting infectious prosthetic valve and cardiac implant electronic device where there is increased metabolic activity and high inflammation response on the prosthetic valve. The PET-CT is particularly important for prosthetic valve or seed endocarditis or extracardiac foci of infection and the embolism of the infected material. Now, unique issues in that drug use associated endocarditis is relapse and recurrent infection are common. Traditionally, relapsing endocarditis has been defined as second episode of infective endocarditis with the same microorganism within 6 months after the initial episode, whereas recurrent disease is defined by more than 6 months separation from initial or subsequent infection. Persons who inject recurrent drug use may lead to repeat bacteremia less than 6 months from the last episode of infective endocarditis, which can complicate the clinician's ability to properly classify repeat episode of bacteremia and infective endocarditis, either relapse or recurrent. Molecular techniques here can help. And because of valvular abnormalities may persist after acute infection, American Heart Association and ESC recommend at end of antimicrobial therapy transthoracic echo to establish new baseline valvular morphology. Now, unique issue in antimicrobial therapy, clinician should do Gram-Stein information immediately and empirically shoot antibiotic, already discussed by my previous speakers. Whereas standard treatment of infective endocarditis involves 6 weeks of antimicrobial therapy, guidelines support in these particular patients use of abbreviated treatment. Because abbreviated regimen can have benefit of less exposure to antimicrobials and when relevant, less time with indwelling catheter in place. Now, medication interaction in this group of patients is also important. Rifampicin use of Staphylococcus infection is a potent enzyme inducer. Linezolid can have that serotonin syndrome in the setting of opioids. QTC prolongation can be done by that proloquin and also can be aggravated by other antidepressant and antipsychotic drugs. Regarding surgical therapy is challenging in this group of patients because of extensive tissue destruction and perioperative mortality less, long-term outcome are worse when compared with those of surgery of non-invasive radiology. But recent meta-analysis showed that persons with IV drug users had 47% hazard death and more than twice hazard of reoperation than non-drug user persons and 40% mortality for 5 years. And they have made one stop score to risk stratify the patient who are risk for that perioperative or postoperative mortality. There is a patient who was on dialysis, surgery done on emergency basis, multi-valve involvement, active infection, baseline lung disease, and prosthetic valve endocarditis. They have got the more chance of that developing that increased mortality. Pre-operative mortality ranged from 19.7% when stops point is 0 to 84 to 85% when 16 stop point, and predicted operative mortality ranged from 0.5% with 0 stop score to 56% with 27 stop score. Now, regarding choice of valve, that it has been shown that who have undergone bioprosthetic valve is more commonly used because of the long-term anticoagulation can be problematic who are already on IV drug.
But optimal DAPT duration.
Then one new modality has come that percutaneous mechanical aspiration of the vegetation.
You know the score. One is the precise.
And this is the angiovac system.
On the day.
Angiovac system that they performed using continuous suctioning of the circuit that allow aspiration of lesions of interest, filtration of blood, mix and reinfusion to filtered blood into the patient. General anesthesia here is needed because it is a venovenous extracorporeal bypass requires large bore access. On video. But there are some limitations of that vegetation, PMA of vegetations. The residual vegetations commonly stays at the end of the procedure, and it is designed only for the right-sided endocarditis. But it has got definite value in debulking the Parkinson's vegetation, whether increased risk of recurrence.
And Dr. Saroj, can
Yes.
you conclude?
That persons with IV drug use needs multidisciplinary approach. That starts from the cardiologist who assess the infective endocarditis and its complication and provide acute management. They needs intervention cardiologist who do that Parkinson's mechanical aspiration. They needs infection disease specialist who do the prompt diagnosis of the culture and the guide regarding that medical management. Needs cardiac surgeon, needs the social worker, that addiction medicine specialist and case manager. Now conclusion, prevalence of drug use associated endocarditis is increasing dramatically over the past decade, but unfortunately very limited data. Recognizing that it needs long-term prognosis, needs successful treatment of substance use disorder and incorporation of harm reduction. The cardiovascular team will only be successful treatment of this patient population by working closely with other care providers and incorporating focus on addiction treatment and providing appropriate social, psychological, and financial support to patients starting as early as possible. Thank you.